Next up, you can see we have a full panel of people from the State Department of Healthcare Services, and we're going to start out with Dr. Karen Baylor, who's the Deputy Director of Mental Health and Substance Use Disorders for the Department of Healthcare Services, appointed in, it seems like a while ago, but it was only 2013.
It's 2 years. It's been
Wow,
2 years.
2 years. Prior to that, she was the Behavioral Health Director for the County of San Luis Obispo for 8 years, and during that time, she also served as the President of the California Mental Health Directors Association and served on the board of the California Mental Health Services Authority. So it's been very welcome, I think, to all of us who have someone at the helm who actually understands how the work goes at the local level. So that's been incredibly helpful. And she's also got a great staff, and I'm going to let Karen introduce her staff. I sometimes look at the amount of work these folks have on their plate, and I wonder how you survive it. You're still here, and that's the good news. So welcome, Dr. Karen Baylor.
Thank you so much. Nice, thank you. We are actually very, very honored and grateful to be invited back every year, so thank you, Sandra. I originally was thinking about coming alone, and boy, am I glad today I chose not to do that. So I appreciate that I have really passionate and committed folks working together as a team. And we have a great deal of work to do, but we've got such a committed staff and really passionate about the work that we do. So I'm going to start at the end with the farthest away from me, which is my Assistant Deputy Director, Brenda Grealish. And she has now fully assumed all of those job duties, and I'm very happy to say she's right next door to my office. So there are numerous times when you hear, Brenda! Coming from my office, and she always shows up with a smile. So I'm very grateful to have Brenda. Next to her is Dina Kokkos-Gonzales, which many of you know has been a lead in mental health for a number of years for the state, and is also a knowledgeable and fabulous partner. Next to her is our newbie to the team, except it's been more than a year, so you can't be a newbie anymore, Don Braeger, and you'll know him from substance use disorders. So he is from DHCS, SUD, PTRSD, and he hates the name. And so he is going to be announcing a change to his department name, and I told him you all won't really care one way or the other, that it's not vital to the work that you do, but it's really important to him. And then my partner in crime next to me is Marlise Perez, and she and I can't help but give each other the thumbs up when we hear about the impact that our Drug Medi-Cal waiver is going to have, not just here in California, but nationwide. And I couldn't ask for a better partner who's really committed to SUD services. And it's been quite the wild ride this last year in really trying to envision what an organized delivery system would look like, but then now we have to put our money where our mouth is and actually implement, in the words of Al Sanilla, do it now. So he's never shy to poke us with, how about now, how about now, how about now? So I'm very, very grateful to have these folks with us. And we each have some things we want to talk about today, but I do feel the need to start with what we heard previously from the federal level. I want to hopefully calm some of the anxiety down. We do feel as if we have a very strong organized delivery system within mental health. We are working very hard to replicate that on the Drug Medi-Cal side. And so we work very, very closely with our federal partners, with CMS. Dina has a hot phone, one of the red phones that automatically dials into CMS. And, we were frankly told we're not going to get a 1915B waiver. You're not going to get a 1915B waiver for 2 years. And look at what happened. We got a 1915B waiver for 5 years, which is really a lot of credit goes to Dina and her ability to negotiate with our federal partners to do what is the right thing for California. And I think California is a very unique and different system. As you know, it's a very large state with lots of diverse needs. And sometimes I think it's easy to just look at one cookie and think you've seen one cookie, but we're a different cookie. And I think that we are working towards all of the things that were mentioned earlier, and we're going to give you highlights of where we are with all of those things that we are working on that is important to our system. But we are not hearing anything from our federal partners about the carve-out going away. The funding is unique in how it's done here in California. The legislature has made it very clear. With not just doing 1991 realignment, but guess what? They did it in 2011. I think the administration's philosophy is to have the money down to the level where government provides those services and to be able to make those decisions as what is in the best interest of that community and that local level. So I just want to calm folks down. I absolutely promise that if we hear anything differently, we will tell you. But we are not hearing anything differently about the carve-out going away. In fact, we think we have a very strong system. We think we're building it to be an even stronger system. And we've heard of states who originally had a carve-out, left the carve-out, and are now going back to the carve-out. Because we know how, we're the specialists in behavioral health. We know how to deal with these folks, and it's not office-based visits. And so it's a combination of efforts. And so while the managed care plans do have responsibility for the mild to moderate, I don't think anyone really realizes the complexity of dealing with specialty mental health services and the variety and wraparound services that are needed for those folks. So I just want to assure you that we are hearing nothing different. Okay, so let's refocus now, and we'll go back to some of the things we want to talk about. I traditionally sit down before a policy forum and write down my top 10 issues, which usually go to 20 or 25 as being really the top issues. And so I want to just give you brief updates on a number of those, and then I'm going to pass it on to folks who are going to go a little bit deeper into some of these issues. Marlise will be talking about all the different efforts with the waiver. Brenda's going to talk about the CCBHC. Don is also in partnership with Marlise on the waiver and has all the fun tasks of changing the IT system, doing the state and county contracts, and all of those really fun things. Right, Don? It's fun.
Yeah, it's fun.
And then Dina, of course, is going to talk about the STCs, which are connected to our 1915B waiver. But we have heard that there's a number of issues that, and these are not in any particular order of importance. It's just they're all important, and so I'm just going to dive in. Today is October 1st, right? So you all know what today means besides the federal government. For us, it's ICD-10 day. And so the switch was flipped and we're all into ICD-10. And I did have some talking points on it that the DHCS gave us. I left them in my room. So if you have any questions, I may need to get back to you later. But really what I want to talk about is the interaction between ICD-10 and DSM5. We've started conversations with CBHDA and others quite a while ago on what's the intersection, what's the value between the two, and really DSM is a clinical tool. It needs to be a clinical tool. It is not a billing tool. And so we do everything off of ICD-10, and that's the billing tool. And so we're really looking to convert totally over to ICD-10. And so what does that mean for DSM-5? We're working on an information notice to come out to say, you should convert. We should be up to date clinically with DSM. But when we revise regulations where we define medical necessity criteria, We're going to do it in ICD-10 language. Now, I know there's not a one-to-one relationship between ICD-10 and DSM-5, so that's where we've been working with some of you and our county partners to figure out what that relationship is with some of the diagnoses that don't quite match up. But it was kind of interesting to hear someone from DHCS the other day talking about how the ICD-10 codes are so now expansive to where it's like if you have a finger injury, it identifies which part of the finger it actually is. I mean, they've gotten really into the weeds and down deep into that. And so just from the state's perspective, ICD-10 is the direction we're going. What does that mean for you when you go back home? If you haven't converted to 5, start thinking about it. It's really just in the documentation. What our triennial folks will do is they're looking for how you built the house. So you start with the assessment. You then come up with a diagnosis. You then come up with the client, with the treatment plan, and then your progress notes have to relate back to the intervention identified in the treatment plan. That's what our folks are going to look at. They're not really concerned. They look at ICD-10 as well. They're not as concerned about whether you deal with DSM-4 or DSM-5. It's a clinical tool. And so we will come out with some sort of date that says, you all should be converted to DSM-5 by, I don't know, January 1st, off the top of my head. But in the meantime, we'll continue to put into that information notice about how we will align ICD-10 and DSM-5. But don't get too hung up on, I haven't converted yet. It's not that big of a deal, because really the foundation for us is the billing perspective, which is ICD-10. So I hope I have not confused all of you, but more to come on that. But that's the direction we're headed. Let's talk about the other thing that is really interesting to most folks, which has to do with money, and that's realignment based in growth. SCO recently distributed the $60 million of growth for 13-14 to the counties, so they now have that. We are having discussions currently on realignment base for 15-16. And then hopefully you all saw the announcement that October 16th, is it 2 to 4?
I think so, yep.
2 to 4? We're having a big stakeholder meeting to talk about the growth, which is, I'm hearing anywhere from 140 to 150 million. Now, let me do a little table setting for you. What the statute says is we are able to provide some input to CSAC in consultation with CSAC and the Department of Finance to say, here's what we think the allocation methodology should be for growth. But we're not going to go in and say and I'm not picking on anyone, but all redheads who are right-handed need to have access to this money first. That's not the purpose of the stakeholder meeting. The purpose of the stakeholder meeting is to say, what are the factors that we should use in looking at how we distribute growth? Should it be based on poverty rates? Should it be based on penetration rates? Should it be based on a combination? That's what the conversation's going to be regarding how we distribute the 150 million. So just heads up on that one. We're still really in the thick of things with KDA. Dina has been having regular ongoing conversations regarding TFC, which is the last program that we need to roll out for KDA. As you know, we've been working very closely with CMS on the SPA. This is an older SPA. It's a billing methodology kind of SPA that we're working with for TFC. And so we've gotten things pretty much worked out with CMS on TFC, but there's other parts of the SPA that they're still asking questions. And let me tell you, no matter what you've been through, CMS asks far more questions than you've ever seen in your lifetime. And it's not just once. You don't just get one bite at the apple where they ask questions. They come back and they come back, and they come back with more. And so Dina's and Brenda's teams have been working very closely with CMS, trying to get all the responses. We're hoping the SPA is currently off the clock, so we're hoping to get that back on the clock sometime this month, which means then they have 90 days to approve, and hopefully it won't take that long because, once again, in the Alcinella world, let's get this implemented. So I know there's a lot of interest out there in getting TFC implemented, especially because of 403 and all the things that are happening. It's just part of that continuum of care. So the other thing is we are doing community teams now on a regular basis. We do know that there needs to be a TFC sort of manual or guidance that will need to come out. There is a TFC work group that I think is working on some of it. Yes. Oh, I'm sorry. Therapeutic foster care. I'm so sorry. We get to talk in acronyms and I forget. So yes, so that's the latest big piece on therapeutic foster care, and any other KDA kinds of questions that you have, Dina is your gal. Brenda's also going to talk about the performance outcome system that has gotten a lot of work, and we're getting ready to post some new information, so we're very excited about that. There's been a lot of talk about the crisis services lately. I don't know if you've been watching. The OAC has been holding some work groups, are they sessions? What are they calling them? I'm looking at you. Advisory committee, thank you. Talking about crisis services. We are getting ready to release a survey out to the counties that should happen this week. To actually get a lay of the land of what counties are providing. So there is a requirement that counties provide crisis services. Mobile crisis is a may. You may provide this. And so we really want to get a lay of the land of what's happening out there, especially with MHSA and more work being done on the community level. We're happy to share the results of that survey when we get it. So just to let you know, we are working and very interested in finding out where there are gaps in crisis services, if there are any gaps in crisis services. 403 I mentioned a little earlier. I think Brenda's going to talk about those efforts. The integration plan, I want to talk a little bit about that because as you've heard today, we're talking a lot about integration, and what I usually do when I start talking about integration is everybody defines it a little differently. And so one of our tasks that was actually put into the Drug Medi-Cal waiver is that we need to develop an integration plan. And we've been working on this and actually have looked at SAMHSA's model, which is a tiered model of how they define integration, and we really like that model. And so we're looking at developing a document that we will be sharing with stakeholders for input of what does integration really look like? How do you really define it? Does it really mean co-location? Yes, no. Does it mean coordination of care? Yes and no. And so we really want to be able to provide some guidance, but we also want your feedback on that as well. So as part of the expanded benefits, you know, all the managed care plans are supposed to have MOUs with the mental health plans in order to talk about the mild to moderate and how there will be coordination of care, especially with the moderates. And so we have regular ongoing meetings with managed care plans, and we're starting up with the mental health plans as well to be a part of that group to really talk about what's working, what's not working, what are some best practices, and then to be able to share all of that with you. Two more things I have. One is one of the other issues that we're really working a lot on is the psychotropic medication in foster care and inappropriate use. There have been a number of hearings at the legislature. There's another one coming up. We've worked very closely with our DSS partners in a data sharing agreement so that we can actually look and see what's going on. But that's just one of the efforts. There's a lot of other efforts. Our pharmacy benefits have come out with clinical guidelines. There's an FAQ that's posted. But there's a lot of work on really looking at identifying where there is the problem, we've worked closely with the medical board as well to look at some of the practices and to be able to see if there are appropriate uses of psychotropics, specifically antipsychotics in children and youth, and how we can change that. So just wanted to give you a heads up that that's still on the radar. And then the other thing that I really, seriously, I really appreciate you guys when you send me emails. I really, really do, because it's my way of knowing what's going on. And so I got a flood of emails when we started having some documentation trainings that weren't going in the direct, there's rumblings, that that wasn't really clarifying and helping. Is what I'll say. And so we are having regular ongoing meetings internally to clarify and then be able to get back to you with some really specific answers to those questions, such as, how do you bill for family therapy? What's the difference between transporting and travel and those kinds of things. So we're working on that to give you some clarifying information. But we did tell the counties, don't change any of your policies based on the documentation training until we come out with something, I've been in this field a really, really long time and have always heard about difficulties with documentation. And clearly, I don't want to make it more difficult. We are trying to see where we can streamline some of the documentation requirements, because we don't want your clinicians and your staff spending all of their time documenting and not being able to provide quality care. So just to let you know, we're continuing to work on that. Thank you. We also have 13 two-year bills, which means that the work doesn't stop. We continue working on all of those bills, one of which is two of which are, I think, important to you all. One will be the out-of-county foster care. We're still working on that piece. And then the peer. And so we've started having regular ongoing meetings with counties to really look at the bill and with their author, the bill's author, to see how we can do this right. This is another area where we agree that the peer support is really important and we want to implement it, but we want to do it right. And I don't want to do it quick and then have it not work. We want to do this right. And there's a lot of pieces for it. Someone reminded me not too long ago that it took the LPCCs 5 years to get up and established, and we're trying to do this in half that time, even less than half that time, with all the other things that are going on. But we're very, very interested and we're committed to getting this done. But it is going to take some time to kind of really work out what the infrastructure will be, how will this work, what are the requirements, what will be our authority to have oversight and monitoring of that. So those are just some of the high-level issues. And now I'm going to pass it on to Marlies to talk about the Drug Medi-Cal waiver.
Great. Thanks, Karen. So as you can tell, we love to have fun in our area of mental health and substance use. It's actually quite fun at DHCS sometimes when they see us all get together, because we're quite a force. And I think we really take a combination of the passion that we have for this field, but also the tremendous weight that we carry all the time. And I just was at our NTP advisory group yesterday, and one of the providers were talking to me about the folks that they have on wait lists because they don't have enough capacity, and how many people died because they couldn't get into treatment because they had a few slots open, they went through the list, and the numbers of people that died. And I just sat with that and saying we're moving, we just have to keep moving forward in this field. We do have spotlights literally in this room right now, but we have spotlights on this field because it's been pushed to the side for far too long on both sides, on mental health and substance use. So it's not just us up at the table or at the federal level, it's everybody in this room that I know is constantly pushing and moving things forward. And I did want to start with, we have put a lot of effort at the department in getting our Drug Medi-Cal organized delivery system waiver approved. And I mean tireless amount of time. And in the words of our former director, he says, well, that is great, but the real work is in implementation. And I was like, oh my gosh, he's so right. But I'm already so tired, Toby. But then, yes, we got approval, and let me tell you, the celebrations that we had were amazing for 5 minutes, because then we said, now we have to get to work. And but we have a renewed excitement. We are just moving as fast as we possibly can. Al, I don't know where you are, but we are, there he is, but we are moving as quick as possible. And really what the waiver provides counties and providers is a framework. The standard terms and conditions are the framework, but what we really want to see from our counties is innovation. We want to see, how is this going to work for you at your county level? Because counties have various parts of the system that already work. They have these pockets of innovation that are working, and then they have in other areas severe gaps. But for each county, it's very different. So we're very excited to receive county implementation plans. We have heard from our phase 1 counties that there's a few real early adopters that are aggressively going to submit in October or early November. So we can't wait to get our hands on those and just see what, at the county level, those stakeholders and county partners and groups come together.
Can I just add one thing? I remember really clearly when we rolled out MHSA. Do you all remember the first county that submitted a plan? Was Stanislaus. And so I'm like talking to the Bay Area about who's going to be first, because you will be remembered as the first county. Thank you.
Thank you, Karen. I actually have a pool going to see which county's going to be first. So I'll let you know if I win. I'm actually the only one in the pool, so I am going to win. Just saying, hey, you know, you got to stack the cards sometimes. So, but we do have some really serious gaps in our system that, and a lot of it has been already highlighted this morning, but we really are hoping that the waiver can begin to lift up this system. And as we're lifting up the substance use system to get it closer to the mental health, and then coordinating there, and then closer to physical health, there are tremendous gaps. The one being in medication-assisted treatment. And I was just fortunate enough to be back in Washington, D.C., because Secretary Burwell brought together all 50 states to talk about her initiative and what efforts were other states taking on. And what was interesting is the director of CMS highlighted our waiver as one of these efforts, in seeing that we are accomplishing with our waiver 2 of the Secretary's initiatives. One is access to naloxone, and the other is expanding medication-assisted treatment. But these are not going, this looks great on paper, but these are not going to be easy lifts. We don't have NTP providers up north. We don't have providers using buprenorphine. Protocols have to be established. All types of work is going to need to occur in this area, and it's going to take some time to get these systems up into place. And then the second is that care coordination. And like Karen talked about, I think care coordination is just as elusive as integration. Care coordination, everyone is talking about different. Is it with mental health, physical health? Is it with the criminal justice system? Are we talking about the foster care system? I mean, these clients that we have, when we really put that client in the middle and the systems on the outside, a lot of us look in and say, hey, we're all serving the same person, but we're trying this angle, we're trying this, but really coordinating that system approach. That is going to take a tremendous effort. It's not getting the clients across the bridge. We have to build the bridges and then help get those clients across. So we're going to have a tremendous lift there. And then also bringing up that continuum of care of services. And while we are absolutely thrilled to be able to offer residential services as a part of the continuum, that's just one piece of it. We're adding whole new services in the area of recovery services. We have typically said in the SUD world, you complete treatment and we let the person go, yet we know relapse is a part of the addiction. And then we're befuddled that they come right back in the other door. So that recovery services, what is that going to look like? How do we really reach out to that client and have them reach back into our providers? So I think I'm very, very excited to see what we can innovatively do in that area. Physician consultation, case management, the list goes on. But really building that continuum and having it functioning, that's going to be a lot of work. So with that, what the department is doing is recognizing that we need to do a lot of education, we need to do a lot of training, technical assistance. We will be releasing in the next few weeks a request for proposals. The legislature has given us some money for training and technical assistance. That's one piece of the front that we're going on. Another is we have, very excited, some foundations have approached the department that are very interested in the behavioral health field. The California Healthcare Foundation is already funding us with some consultants. One in the very back of this room, and I'm going to call him out right now, Don Kingdom. He's very famous here in this. There we go, yes. He's going to love me for that later. But having folks with the subject area knowledge that can help the department as we're transforming our systems. With the Blue Shield Foundation is very interested in assisting us. We're looking at rolling out some learning collaboratives. We have this phase 1 that is highly innovative and moving forward. How can we take from that and move it out to the other phases? But we really, really recognize that it's going to be time consuming. It takes a lot to get true change implemented. So we're really taking a lot of time at the department to invest in getting the information out as we continue to roll out. Also just want to highlight that we ourselves are wanting to be innovative at the state level. We are working on, right now, our residential providers all need to be ASAM designated, and some of you are probably like, what's that? Well, we just created it 2 months ago because there isn't any other state doing this, but basically we've taken the ASAM criteria and then laid it on top of what it would look like for a provider to offer those levels of service. So we as the department are going to be designating and are currently designating for the 3 levels that are in our system if that provider actually provides those level of services. So we've currently designated 20 facilities, and we are going to be starting to work on phase 2 in the next few weeks and start working with those residential providers. I do want to announce that we are formally going to start technical assistance with phase 2 on November 1st. So for those of you in phase 2, get those plans going. We are going to be coming into your neck of the woods and starting to meet regionally with phase 2. And so we're very excited about that.
And where will that happen?
Where will that happen? It's like some comedy routine. So we are going to kick off after our conference. We're going to be starting to meet with phase 2, but then at our SUD conference. Oh, so phase, thank you very much, Pat. So we rehearsed this actually last night. So phase 2 is down in our southern region. So that's about 60% of our population actually, but that are our southern counties, including San Diego, for those of you that are here in San Diego. And so that will be starting November 1st. So officially counties then and providers will be able to submit their Drug Medi-Cal certification for the residential. They'll get priority, and then the counties will be able to submit their county plans. And then the department will be focusing in on phase 2. And also just wanted to quickly announce that at the department, we are seeing, while we are making a lot of headway in our provider enrollment division and moving Drug Medi-Cal certifications, which is really outstanding, we are now experiencing in my shop truckloads of applications that are coming in for initial licenses for our residential services and also our alcohol and other drug certification. So we're really working on trying to see how we can move staff to take care of those efforts as well, because the response that we're receiving is quite overwhelming and very exciting. We are really attempting to adhere to our 90-day timeline in order to move those applications. And then I also just want to state that we are having a webinar on October 22nd, just to go over the approved standard terms and conditions. So if you have not been a part of that and are interested, we do have information posted on our website. And with that, I just want to, I'm going to turn it over to Don, but before I do, I just really, really want to continue to applaud the efforts that you are making in this room. We could never do the work that we do without you. I know that there are partners in this room that I call on frequently in my moment of need of wanting to know what's really happening out on the street and to maintain that connection. Because while we are afforded a tremendous opportunity here to set state policy. We can't do it in a vacuum. And in working with some of our foundations, one of the members said something to me that was really exciting, and I really liked it a lot. She said, I'm so used to working with the physical health providers, and they're great, but she says, there's nothing like your behavioral health partners. She says, the excitement and energy, she said, it's just so different, and we're really enjoying learning about your fields. And so that is really hats off to all of you. And unfortunately, we don't always get the clients that are able to thank us, so I just want to make sure to take the opportunity that we really want to thank you for all the assistance that you give us. And with that, I'm going to turn it over to my partner, Don, and he's going to tell you about his efforts.
Good morning, everyone. I love going on these trips because, as you can recognize, I'm the only male on the team. So I learn a lot about shoes. I also know where all of the outlets are. There's one right down the street around the corner. Last night there was a drive-by where we heard all about it, so I know everything that's in those strip malls. But seriously, it's a lot of fun. This is a great team. So some of the things that are going on in my area, and I know Karen joked about the acronym, but it really is irritating when you have to say DHCS, MHSUD, SUD, PTRSD. So we're going to become the Policy and Fiscal Division, which makes more sense and aligned with what we do. So a couple of things, and I'll pass it on to Dina, but in regards to the waiver, like Marlise talked about, is really building the framework and the conceptualness of the STCs, and then my shop is really responsible for taking that in the literal sense and building out things. We have a lot of challenges. The transition between the former department to DHCS, we're left with, I think there are 6 systems that we continue to work with, one of which is Short Doyle 2, which is the main component for this waiver. So we have a lot of challenges from the perspective that in the SUD world, the rates, as you know, are standard rates for the services. Under the waiver, we'll have to mirror more of the mental health side, we'll have variable rate structure. And so from an IT perspective with our outdated systems, it really, really is challenging, but we're moving along. I feel really good about where we've come in the last 6 months, taking a look at how we're progressing and being ready to get ready for those components. We also, like Marlise talked about, we're working closely with Don Kingdon, and he's great with the finance piece, talking about the sharing ratios, what those will look like, and then really building the Short Doyle billing manual just for the waiver. I know we just released the DMC billing manual, it was about 3 weeks ago. We'll also be putting out a new billing manual that'll walk everyone through the billing codes and how that's going to look for the Short Doyle system. So those are just some important components for the waiver. The last piece, I know we need to get through some other components, but it is the contract. The contract will look very different than what you're used to, because it will have the normal contract structure, and then it'll have components some of which we integrated for the 15-16 recent contract, but it'll contain more of the mental health plan language and the CFR 438 requirements, which Code of Federal Regulations, which are mandatory requirements of the waiver. We will have some walkthrough, and we will have some TA on this, so it's not totally foreign, and we're not just pushing out this contract. So it is a little bit of a new world for certain components of the contract, and again, our goal is to walk you through that to make sure that everybody understands those components. The last thing I just want to announce is the Substance Abuse Prevention, or SAPD, block grant that we are responsible for submitting. It's due October 1st. It was due today. Due to the incredible work of the team, they submitted it early this year, September 18th. And the reason why, not only am I celebrating that it's early, but this year we're not really clear why SAMHSA came out with an application that had 22 factors, and each factor had between 3 and 12 indicators that we had to respond to. We're not really sure why SAMHSA came out with such a lengthy application. We're not sure if it's the uncertainty of where they're going with the funding. Certainly our waiver is impacting what SAMHSA is looking at in terms of the use of SAPD block grant funds, so we're really happy about that. We're working closely with them and John Perez, our partner for our region, to take a look at how we're going to repurpose those funds. I want to touch quickly on housing. I know that came up earlier when Hannah was up here, and I've had a lot of emails in regards to the use of SAPD block grant funds for the use of housing. So the reason we've been a little sketchy on this is we've had some conversations with SAMHSA, and they've put things in emails, but it's not been official. The reason why is they wanted us to, because of the request we had for the use of the funds, is they wanted to go ahead and have us wait and put it into the grant application. So it is in the current application. We have responded the use of using SAPD funds for housing. So the policy will be, and we'll put more information out on this, once our grant application is approved. We have to wait for approval, then you'll get an IN that'll be published talking about the proper use and allowances of using those funds for housing. So it, you know, I think at this point they're pretty strict about not using the funds for incarcerated populations. But the use of housing, we'll go ahead and develop a policy and work with the associations to get that information out. So I think that's all I have from my perspective. So I'll pass it to Dina.
Thank you, Don. Everybody still with us? All right. Before I dive in and start talking about the waiver, one of the things that I'm reflecting on just as I'm sitting here, the focus is on integration, or one of the focuses on integration. And we're sitting here today not as three different departments, the former Alcohol and Drug Programs Department, the former Department of Mental Health, and the Department of Healthcare Services, but we're sitting here as one department with those services integrated within the department and having a really strong and passionate team and under leadership of a former county mental health director. And I'm just so excited about how far we've come and where we're going and the collaboration and strong relationships that we have built with the counties and providers. And so I just felt like I needed to reflect and say that. So another thing I'm excited about, the 1915B Specialty Mental Health Services waiver. Currently, we have a 5-year waiver renewal beginning July 1, 2015, or began July 1, 2015 through June 30th, 2020. And as I think everybody knows, we've in the past have only received 2-year waiver terms. At one point, we even received a 1-year waiver term because of some issues that were happening within the waiver and within the program. But really, I'm happy that I'm here in front of you talking about a 5-year waiver approval for the first time ever. And it couldn't have been done without partnering with our counties, with CBHDA, and with our counties, and really rolling up our sleeves and digging into areas of focus and improvements and just collaborating and having federal CMS acknowledge what we're doing and where we're going and recognizing that and getting that 5-year approval. So thank you to you. We did receive special terms and conditions. For a 1915B waiver, special terms and conditions is unique. It's not so unique. It is what an 1115 is constructed of, and it's not as unique for 1915C home and community-based services waivers. But for a 1915B, it is unique. So although we received a 5-year waiver approval term, we do have special terms and conditions that reflect some work and improvements that we need to happen in the 1915B waiver, and we've got some time to work through and implement some changes that are necessary. So this is an opportunity for improvement. The special terms and conditions really shouldn't come as a surprise to any of us. Through the last waiver term, CMS has been talking to us about some areas of focus and areas they wanted to see us improve, and we've been very transparent with our counties, with our providers about those areas and work that needs to be done. The theme around the special terms and conditions are around transparency, access, timeliness, quality, translation services, and overall improvement in those areas. So we have, let's see, I think it's 7 special terms and conditions, 7, and a couple very key special terms and conditions. The first one being that the state must make readily available to beneficiaries, providers, and other interested stakeholders a mental health plan dashboard that is based on performance data from each county mental health plan, and then also includes information from their providers, from the mental health plan providers. So this is a big endeavor on what would the dashboard look like, what should it include, and how does it reflect the things that CMS wants us to reflect on that can be presented in a way that's easily understandable and summarizes quality, access, timeliness, translation, interpretation capabilities, and performance of each mental health plan. So the good news is, as a result of conversations we were having in the past with CMS about some of the areas of focus, we had started working with the counties around a metrics work group. Previously, there have not been any standard uniform measures amongst counties. Counties set their own policies around timely access to services, have some of their own definitions or interpretations of that, and that the data that they collect. So although our EQRO goes out and looks, really we're measuring apples to oranges, and it's not been apples to apples. So we tell a story, but it's the story with the best data that we have available, and it's not really accurate. But now, for the first time, we're sitting down, we've got a handful of proposed metrics that will be implemented and standardized across all counties, so we can really paint a true story of what's happening and really set a baseline amongst all counties. So there's a lot of work that's been done in advance that now we're just going to take on a little bit more when we talk about the dashboard and what needs to be added. So although it's a heavy lift, we've already started doing a lot of the work, so that's the good news. The second special term and condition is around the state requiring each county mental health plan to commit to having a system in place for tracking and measuring timeliness of care, including wait times to assessments and wait time to providers. The state needs to establish a baseline of each and all counties that includes the number of days and an average range of time it takes to access services in their county. And then also, if a county mental health plan is not able to provide this information so that we can establish the baseline, then we need to look at doing some statewide performance improvement projects, some statewide PIPs around timeliness. So when I read these or when I'm talking about this, the good news is we negotiated, because CMS wanted just off the top everybody do a statewide PIP. And we were like, well, there's some counties who could use a PIP to do some other things and have good timeliness. So, having these conversations, so when I read these, they've been negotiated, I think, fairly well, that hopefully will work for the state and the counties. So that having a statewide PIP if necessary, establishing a baseline, and being able to collect data from the counties to establish that baseline is what the second special term and condition is about. Those, I think, are probably the biggest special terms and conditions that we have some time frames that we need to adhere to, and that will require some work as far as data collections, definitions, and just working through these processes. But the good news is it's going to get us to a much better place. We're going to be able to tell the story. We're going to be able to measure improvement, and it's just the right thing to do. The third special terms and condition is about the state providing the EQRO quarterly and annual reports regarding the required PIPs to CMS, and then we'll be discussing those findings with CMS during our monthly monitoring calls with them. The fourth one talks about publishing on our website or on its website the County Mental Health Plan's Plan of Correction as a result of the state compliance reviews. We will also need to be posting the quality improvement plans from the counties, and the intent is to be able to identify the County Mental Health Plan's goals for quality improvement and compliance. So initially they wanted a lot more, CMS wanted a lot more, and we said, well, how about if we do it this way? The plans of correction, the quality improvement, it's something that already the counties are doing, and then they want us to be transparent in posting those. The fifth one has to do with the state and county providing to CMS the annual grievance and appeals reports. The sixth one has to do with all information being published to the STCs being placed in a standardized and easily accessible location on the state's website, because anybody knows when they've gone to our website, it's not very user-friendly and it's not easily accessible. So again, it's just about improving transparency. And the seventh one is really standard language that CMS incorporates, which says the state must, within the time frame specified in law regs or policy statements, come into compliance with any changes in federal law regulations or policies affecting the Medicaid programs that occurred during the waiver period. And that's just really standard language and a standard assurance. But also, I believe this was intended because they knew the Medicaid managed care regulations would be coming out, and they weren't far enough along to really be able to impact the waiver or have those conversations. And I think that's also intended just as a heads up. Things might be changing, and that we'll comply with those changes. So those are the special terms and conditions that we need to adhere to. Part of adhering and implementing those special terms and conditions require process improvements from the state and from the county, and probably trickling down also to our providers. But when we talk about process improvements and we talk about changes, it's done collaboratively, but some of the things, it's not intended that it's only about the county, because the counties are the ones who are providing the services. It's also at the state. An example would be, we have our compliance protocol, our system review protocol. It didn't tell the full picture, it didn't tell the right picture. We had a number of questions folded up into one question, a number of components into one question. County was either in compliance fully or out of compliance. There was no story of partial compliance. So a county who was 80% compliant or 90% compliant but missed a component of an item looked the same as a county who was 10% compliant. And that's not telling the right story. That's not giving CMS the right story. And so we had some improvements to make in our compliance protocol, our review protocol. And then also we made that for 14-15. And then now for 15-16, we incorporated some changes for the chart reviews, where we're also breaking down. And then also it's about telling the right story, but it's also being able to provide the right information and technical assistance to the county, so you know what component and what piece you've missed. So by breaking them down into different questions and then just having more accurate information, I think is just a win-win all the way around. At the state level, we need to enhance our monitoring activities. So that's something that we're looking at. What does that look like? It's not just about monitoring activities. It's also about technical assistance. What does that look like? How do we provide good trainings, the documentation training that came out? It wasn't exactly what we had hoped for, but we did learn a lot from it. And we do want to partner and collaborate with the counties and hear what would be helpful to you all as we go forward with implementing changes and trying to improve compliance. And there's been a lot of work that I mentioned around developing the uniform statewide metrics And I think for the sake of time, I'll just stop there. There's more information I have on quality improvement efforts that are going on. I will say that one of the efforts that we will be having to move towards and developing a process is around sanctions, fines, and penalties. And although none of us like to talk about that, and I can even feel Dr. Baylor to my left squirming right now, I see her in my peripheral vision, because that's not where we really want to go, but it's where we do have to go, and CMS has really been forcing our hand about that. And so what we want to do is we want to have a continuum where we start with technical assistance and trainings and focus and targeted site reviews and just doing the things that we need to do, establishing, statewide uniform metrics, doing benchmarks, measuring improvements, looking at PIPs, doing all that, and then getting to the point at the other end of the spectrum where we do have our fines, sanctions, and penalties that we need to implement when we've exhausted other means. But we'll be working with CBHDA, with the counties, with stakeholders to make sure that what we do look at as that process to implement is something that's reasonable, it's fair, it makes sense, and it works for the state, and it works for the feds, and it's, again, transparent to our county partners and stakeholders. So with that, I'll stop. Thank you. Brenda?
Yes, thank you. Thank you so much. I guess I'd just like to start off, I don't even know how I could follow you guys in talking about the wonderful things and working with each other, because it is, as you can see, we're kind of schmoopy on each other. We really enjoy working together, and I think that the best part of that is that it really reflects in the work that we do, and it also helps with the relationships. Having good relationships with one another helps with our relationships as we work with our partners and our stakeholders. And being the state, we want to make sure that we provide leadership. That's part of our role, a major part of our role, as you all provide so much leadership within your communities. So I think as we all work together, that's why so many wonderful things are happening right now in mental health and substance use disorder services. So I just want to definitely give a shout out to everybody in the room for all this work. And I can say even personally, my most recent experience on how this has kind of come to fruition was with the Certified Community Behavioral Health Clinic planning grant. We learned about this planning grant. We learned about it at the end of last year. We provided a lot of input with the federal government, which was great. They took a lot of input, a lot of feedback to really be thoughtful in how they put these grants together. I won't go into all the background on what the grants are, because I think our national experts provided a good framework for what the grants do. We had to pull together this grant in this grant application in a very short period of time, and we quickly partnered with our county Behavioral Health Directors Association. There were several counties that jumped on board to help out. We had lots of folks in the community, lots of stakeholders, other partners, providers who jumped right on in. So we got to work very, very quickly. The grant came out in May. We had to put together this planning grant for, it would be for 1 year of planning for these certified community behavioral health clinics. There's a lot of excitement around these certified community behavioral health clinics, because it really is that idea of that whole person care, that integrated care and co-located care and blended funding care. It's everything that we've been talking about today. So we jumped in, got right to planning at the end of June, had a couple stakeholder kickoff meetings and with DHCS and also with Congresswoman Matsui's office. So there's a lot of interest and excitement. Multiple departments were involved in the planning. We were fortunate enough to have some really good technical assistance provided to us by the National Council for Behavioral Health, and so we definitely took advantage of that. But I think we literally pulled together our first draft of the application within a couple of weeks, and in a major part, and I don't want to forget this partner, our our California Institute, is it for behavior, what is it now? CIB, mental health, yeah, why am I totally blanking on that? I should have that burned in my brain by now, but yeah, I can't even, the amount of effort and work between CBHDA, the counties, and CIBHS was just phenomenal. So we got to work planning, got the applications out, or the draft application out, got a lot of great feedback, and quickly turned that feedback around, incorporated it in the document, and we made that August 5th deadline. So within a matter of 5 weeks, we pulled together this entire planning grant. And the Certified Community Behavioral Health Clinic requirements are extensive. It's not a simple type of clinic. It's really pulling together that integration and co-location of behavioral health, mental health, and substance use disorder services in one location. As we were hearing earlier, there's many, many requirements and standards. So kind of going back to those standards that were once set forth, were resurrected and put forth. So we had to mention how we were poised to do this. MHSA, I think, puts California at a great advantage for that. We also focused on super utilizers because we had to identify a target population. So as many of you might know, there's also a health home initiative or work going on. So the timing of all of this was great because I was able to actually leverage the work from the health homes and apply some of the data and information coming out of that work to our work. So it's almost like health homes are approaching the same kind of target population from a physical health care perspective, and we're approaching it from a behavioral health care perspective. So the work's being brought together in different ways, and we'll see how it all turns out. So we're very hopeful that we would be getting awarded this grant. The grant award, as we heard earlier, is supposed to happen this October, so this month sometime. And we've been working very hard to put together scopes of work for contracting to start, so that as soon as we would get awarded the money, if we're awarded, then we would be able to just hit the ground running. So the planning work is extremely intensive. As I mentioned earlier, you have to develop this prospective payment system or PPS rate. So we would have to have actuarial work done. The linchpin of the CCBHCs is care coordination. So it's not just a matter of referring somebody to physical healthcare services, but it's actually taking those additional steps to actually make sure they connected with those physical healthcare services, and to make sure whatever came out of that, there's a plan and there's follow through, so that those folks, typically vulnerable populations, are getting the care and support and services that they need to be well. And so we'll have a care coordination work group. There's a lot of data required for these CCBHCs, more than I've ever seen in anything that I've done, and I've been involved in a lot of projects with data collection efforts. So there's an extensive evaluation component for this as well. And then I think that there was one more work group that I'm working on. Excuse me, but so essentially. We're just looking forward to this. We had a lot of support from other departments, so if any of you had a chance to see the grant application, it's posted on our DHCS website. If you just Google DHCS CCBHC grant, it'll pop right up. So our grant's online, we have the full application, and then we have letters of support from Department of Education, the Interagency Council on Veterans, Public Health, and Social Services. The other piece of the CCBHC is that even though we're said that we focus on this super utilizer population, a requirement of CCBHCs is that anybody who walked in the door would be served. So that's why you were hearing earlier that it's an FQHC-like type clinic. So again, lots and lots of excitement on this. If we are awarded the grant, we get 1 year for planning. So we would have to submit application for a subsequent application to participate in the 2-year demonstration grant, and services provided would qualify for an enhanced rate. So whereas now most folks get 50-50 match, there would be an enhanced match of, I think it's 65%, so an extra 15 percentage points. And there's a couple other smaller populations that would have a little bit more than that. So that would go live. The actual start date that they're envisioning for these CCBHCs would be January 1. And I failed to mention, and this is the other work group, is the actual certification work group. So because there are so many requirements, we would have to create a certification process to be able to certify these clinics to be able to provide these services. So lots and lots of planning. The application would go in October of next year, and then if we were awarded, which 8 states would be awarded, then we would have to start very quickly. So the other thing is with the performance outcome system, sorry. Just with the performance outcome system, we're continuing to move ahead. We'll have reports coming out this month. Thank you.
That was a heck of a lot of information.
Sorry. So much.
No, I think it really indicates how much is going on in California and how much these folks are so intensely involved in all these changes that are occurring across our state. And all of you are involved too. I did a short presentation to my staff about all of the policy changes going on right now, and I think their eyes were rolling in the back of their head by the time I finished, because there is a lot of work, and you guys really get a lot of credit for helping us with all of this. Really appreciate it. So help me thank these folks.